I want to talk about the advances in the surgical management of melanoma. And I think you say, well, you do surgery, you may not have any advances. But actually, we have quite a few new things that are happening. And especially for me as a surgeon, as Adil talked about, there are many things that we can do as surgeons right now to also really advance the field. And I think we have an important role in patients with metastatic disease as well. And I'd like to share some of those experiences with you. But first of all, I think that these are what I call the many phases of melanoma. These are patients that I've seen that have melanoma. And I think that melanoma comes in all sizes, shapes, locations. And many times when patients are seen in a dermatology office or in a family medicine practice office, they say, well, that's not melanoma. Yet when they do the biopsy, it is melanoma. And I think these things are important for us to understand why are there differences in the way the melanomas look phenotypically when we look at them. I think those differences also come into play then in how the melanoma will react both to treatments but also how it will respond to surgery and other treatments that we provided. Since I'm the first speaker, I thought, well, let's do the epidemiology, a little bit of epidemiology first. I think it's important to set the framework. Where are we and what are we trying to accomplish with this? So it is a lifestyle disease. So at the late 1800s, early 1900s, people did go to the beach, but everyone was fairly clothed. Well, the bikini world happened and things changed. And I think that it really has become in many ways a lifestyle disease. When you look at this in the United States, from the 1950s onwards, the cancer that has increased the most is melanoma. Compared to all other cancers, there's been a 600% increase in melanoma since the 1950s. Right now in Utah, where I practice, the area or the age group that is growing the most in is young women. So it used to be that melanoma was a disease of men who are a bit older, but it is now young women who go to tanning beds. And Samantha and her mother Valerie were very instrumental a few years ago when we, through the Utah legislature, tried to put some restrictions on the use of tanning beds in younger individuals. But this is still a very much a problem. And the reason being is that really the culprit in causing melanoma is UV radiation. And there really is no safe UV radiation. And you have different types. You have UVA and UVB. And they will say tanning beds are safe for you because they use a different type of UV radiation. Still not true. I mean, this is what causes melanoma. And if you think about it, the reason that you get red, like I would do, I don't tan because of my genetic background. Adil is a lot more fortunate from that way. But the reason I don't tan is that I grew up in the northern part of Europe where there's not that much sun. But if you think about it, the reason that we get red on our skin or that we tan, it's a protective mechanism. This is the skin's way of protecting against dangerous UV rays. So anything that you do then has the potential of changing that genetic material in the skin to potentially develop into melanoma. So looking then at this broadly in the United States, we can see that in men, it is the 5th most common cancer. It's about 5% of all cancers, prostate cancer being the most common in men. In women, it's currently the 7th most common cancer, with breast cancer being the most common. What is not necessarily appreciated, if you look at potential life years lost. So what this means is that if you get melanoma, and then you die from your melanoma, you've then lost life years, not only for your family, but also for society. So it is actually the cancer that has the most potential life years lost after childhood cancers. And this is something that's not necessarily appreciated. So this is societally also a very concerning event. In 2015, there will be 73,000 new melanoma patients. These are invasive melanoma, but an additional 50,000 plus non-invasive melanomas. And what that also means is that during the 3 hours we're going to be here together, unfortunately, there will be 3 patients statistically who will die of their melanoma. Fortunately, last year was the first year that we changed that trend. We now have treatments that will help our patients more, and we are changing that trend, and we hope to continue to change that. So what are the melanoma hotspots? Well, I'm not sure I'm proud to say, but it is nonetheless, it's a fact that Utah is now the highest incidence per capita of melanoma in the United States. So it is truly a hotbed for melanoma. You take Northern Europeans, you put them up in the high desert, tell them to go out and ski, and do a few other things, and melanoma unfortunately happens. So we're actually 77% above the national average. California is a little bit above the national average in terms of per capita. And in California, you have close to 9,000 new primary melanomas every year. So let's talk about then how we diagnose this. And what I wanted to do, I wanted to take one of my patients that we've seen and sort of use that as an example of what patients go through. I know many of you have been through this and it's very familiar to you, but I'd like to highlight some of the points and where we may have changed the treatment since many of you or your family members were diagnosed with melanoma. So this is one of my patients, a 23-year-old woman who had a changing mole on her left thigh. And whenever you have these changing moles, it is important that you do biopsies. And Susanna here, she can tell us exactly how to do the appropriate biopsy. But in the community, it may not be known how to do that biopsy. So I think you have to be your own advocate. If you have a changing mole, you have to be your own advocate saying that we want to do this properly, just in case if it were to be melanoma, that you haven't burned any bridges on your treatment. So first of all, when you have a pigmented lesion, you want to biopsy that. You don't do a shallow biopsy of this because you really want to know how thick that melanoma is, and I'll get to that shortly. We don't want to do any electric desiccation. So this is very different from basal cell and squamous cell. You need to know exactly what the architecture of this lesion is. You don't want to have any liquid nitrogen that you treat it with because that's going to change also the characters of the cells. And we don't do frozen sections on these because frozen sections, which are the things that they many times do for basal cell and squamous cell. Frozen sections can be really difficult to diagnose melanoma on. Also, when dermatologists or family physicians, when they do these biopsies, they have to think about if this were to be melanoma, what's the next step? So you have to plan that biopsy based on what you think the next step will going to be. So I unfortunately still see quite a few patients who have a biopsy that transfers over their arm. That makes it very challenging for me then surgically to take it out and to close it up without putting a skin graft on. So we really recommend to do this in the long axis. If you take that out, to do in the long axis of the extremity, which really changes the way we treat this subsequently. And again, I think that any type of biopsy is fine. A punch biopsy, even a shave biopsy is okay, but you have to go all the way through the skin to know exactly how thick the melanoma is. So this is again a patient who has a pigmented lesion. So we numb that up with local anesthesia. We then do a truly excisional biopsy, taking out the whole lesion down to the fat, and we send that off to our pathologist, and they'll let us know if it is melanoma. So for our patient then, she did have a melanoma. It was a 2.72 millimeter breast cell thickness, and I'll come to that shortly. But there was no ulceration. On examination, she had no lymphadenopathy that we could feel. And these days, we don't do any lab tests. We don't do a chest x-ray or any other lab test. This was before when I used to do that, but these days we wouldn't do any of that. If on that clinical examination, the patient has no lymph nodes that feels worrisome, she still is what we call clinically node negative. So how do we treat patients then that are clinically node negative? Well, first of all, we need to understand sort of where the melanoma develops. It develops in the skin, really in the top portion of the skin. And what's important in melanoma is not necessarily how big it's on the surface of the skin, but how deep it grows into the skin. And the reason for that is that deeper it grows into the skin, the higher the risk of getting into the lymphatic vessels and the blood vessels. And that's how it can spread to other places. So that depth of invasion is called breast cell thickness. And we look at this under the microscope. That's very important in determining the risk of spread, but also the prognosis of the patient. So we need to do a wider excision. And say, well, many times you do a biopsy and they say, well, when you did the initial biopsy, all those edges were clean. There was no melanoma at the edges. Why do you need to take more out? Well, this is when I explain this to my patient. I say it's like a bit like your kitchen sink. Sometimes you flush things down the kitchen sink. Most of the time it just goes way down. But sometimes things get stuck. You have to put a bit of Drano in there to clean it out. Same thing with these melanoma cells. They're really sticky. And they can get stuck in those lymphatic channels. And they can sit there very close to where they started. So we want to take those melanoma cells out and take those lymphatics out so that they can't grow and have a recurrence in that area. So that's why we do a wider excision. Well, how wide do we go? There are 5 studies that have looked at this, kind of in less margin and more margin. And based on these 5 randomized studies that were done in the part in the 70s, 80s, and 90s, we now know that, so we've established how much of a margin we need to take around the melanoma. And most of those margins either 1 or 2 centimeters from the edge of where the melanoma was. So that's how we determine how much melanoma we need, or how much of normal skin we need to take around this. When we do that, we try to go all the way down to the muscle or to the deep layers and take that fascia of that layer. And the reason being is that when I do this in the operating room, many times you can see those lymphatics when they track down, they go right along that fascial layer. And taking that fascia out, we then try to reassure that we get all of those cells out if they're sitting in those lymphatics. So we talked about then sort of, again, sort of that the depth of invasion is important because we want to take the lymphatics out. Now, many patients ask me, well, what are lymph nodes? Well, lymph nodes are a bit like your oil filter in your car. They filter things to get the crud out of your oil. Same thing here. The lymphatics are there really to detect any infection in your body. So if you have a sore throat, your lymph nodes in your neck get bigger because they're trying to activate your immune system to fight that infection. Same thing here. Since they are there as these conduits, the cancer cells love them and that's how they can spread. In melanoma, these lymph nodes, where they then go to where the filter is, they tend to be the first area that the melanomas go to. And we have about 1,000 lymph nodes in our body, but there are certain areas where they concentrate. They can be in the head and neck, in the armpits, and in the groin. And those are usually the areas that we're interested in to see if the melanoma has spread to. And is this important then in understanding sort of well, we have to understand what is the risk of the melanoma going to these lymph nodes. So remember I talked about that thickness, how deep it goes into the lymph nodes. So we looked at our database at the Huntsman Cancer Institute, and we found that the more the melanoma went into the skin, the more it grew into the skin, the higher the risk of it getting into the being present in those lymph nodes. And you can see here in these really thin melanomas, it's about a 10% risk. But if you have a much thicker melanoma, it can be up to 30%. And if you have ulceration, even up to 40 or 50%. So this can be a fairly high risk of this going into those lymph nodes. Had we had this talk about 30 years ago, and this patient that I presented here who had the melanoma on the thigh, but on examination had no evidence of any lymph nodes that felt worrisome. But 40 years ago, the way we would have treated this is we would have taken out a very big section on the leg, and we would have taken out all the lymph nodes in the groin automatically. But we know in a patient such as the one I presented with a 2.72 millimeter thickness, the risk of having spread to those lymph nodes is only about 30% statistically. So again, most patients would have had an operation that they really did not benefit from, but an operation that had potential side effects to it, swelling of the leg with lymphedema, higher risk of infection, nerve pain, etc. So in the early 90s, Don Morton, who was at the John Wayne Cancer Institute, who was really the pioneer for the surgery of melanoma, said, well, we need to find a different way. We need to be able to detect if there's melanoma in just a few lymph nodes. And let me go to the next. And what he then really developed, he developed what's called the sentinel biopsy concept for melanoma. The idea here being is that every part of our skin drains through those lymphatic channels to specific lymph nodes. Now, if you think about this in our groin, for instance, it usually drains to between 1 and 3 lymph nodes in the groin. There's about 15 lymph nodes in the groin, but not all of them get the drainage for one part of our leg. It's you have those first draining lymph nodes. Now in Utah, I can't really say this because people won't understand, but we're in San Francisco right now, you'll understand this. It's like going to the wedding. You have the champagne fountain. You have all the glasses stacked up. You start pouring champagne into the first glass. Well, when that glass is full, it then goes down through the stem of the glass into the next set of glasses. Same thing with this. It's sort of the drainage from that part of the skin comes to that first lymph node. It then fills and goes to the second level, third level, fourth level. Well, if you want to find out if there's champagne in that fountain, what you do is you look in the first glass. And if there's no evidence of champagne there, it's unlikely to be champagne in the other levels. Same thing here. If we can find that first lymph node, look at it in detail and see if there's any melanoma there, that will give us a good idea if there's going to be melanoma in the rest of them. And if there's no melanoma there, the likelihood of the rest of the lymph nodes having melanoma is very, very low. So that's sort of the analogy of the sentinel biopsy technique, the way we use it. And the way we find these lymph nodes is that we use two modalities. We inject a radioactive protein into the skin next to the melanoma that travels then to the lymph nodes. And with that, about 90% of the time, we can find the lymph nodes. But we also inject a blue dye in the operating room. And with using these two modalities, about 99% of the time, we can find those lymph nodes draining that part of the skin. And this again, we use a gamma probe to pick up that radioactivity in the operating room. And here you can see that you have those blue channels going to a blue sentinel lymph node in the groin there. We take that node out, and you can see it's blue and it's also radioactive. We send it to our pathologist, and they slice it like a loaf of bread in multiple sections and look at it under the microscope and let us know if there's any melanoma in it. Is this important? And the answer is yes. We did a large study where we asked the question, well, let's randomize patients to have the wide excision only versus a wide excision and do the sentinel lymph node. And we wanted to find out then what was the risk of recurrence of melanoma in these two groups. Now this study had multiple aspects to it, but I'd like to focus on the one in the middle here. In the patients that had the wide excision only, we would then follow those patients. And if at some point in time they developed lymph nodes that had melanoma, they were big and bulky, we would then take those lymph nodes out. So this was sort of when they had a lot of tumor in the lymph nodes, they would take those nodes out. We wanted to compare that then to patients who had the wide excision and had the sentinel node. Now, if on that, when they looked under the microscope, if they saw some melanoma cells in those lymph nodes, then they went back to take out the rest of the lymph nodes to see if they also had melanoma. Same as if you found champagne in the first glass, we say, well, there could be some champagne in the other glasses. Let's take the next level of glasses out as well and look at that. And we wanted to see, was there a difference then in survival in between these two groups, the ones that had the nodes taken out right away versus the ones that had them taken out only when they got big and bulky. And the answer from that was presented recently in a final publication in the New England Journal of Medicine when we had followed these patients for over 10 years. And what we found here was that, yes, there was a difference. The 10-year survival in the patients that had the nodes taken out right away was 62%, compared to 42% in the ones that we waited until they got big and bulky. So this really set the sentinel biopsy as being the standard that we do to identify this. Not because the procedure itself provides any advantage, but it helps to diagnose this earlier. And then we can do additional surgery that we know will impact survival. And also we can then think about additional therapies, systemic therapies that Adil and Alain will talk to you about that really will then potentially also impact survival for patients. So the question then becomes, well, if we take out then that first sentinel lymph node and it has no melanoma in it, we wouldn't do any more surgery. We're done. We've basically identified no champagne in the glass. But what about if we then take it out and there is melanoma? How often then when we go back and take out the rest of the lymph nodes do we find that there actually is melanoma? And the answer to that is between 8 and 33% of the time. So again, the majority of patients don't have any other lymph nodes that have melanoma in them. The question then becomes, well, do we really need to take out the rest of the lymph nodes? Because 70% of the time, there's not going to be any melanoma. And then you have the same risk then of having lymphedema and having other problems from this. So that's why we just finished actually a clinical study where we looked at this called the MSLT II. Now, we don't have the data from this yet, but this study had over 4,000 patients in it, where we sort of said, well, let's take half the patients. We're going to take out the nodes, and like we normally would do. The other half, we're going to follow with an ultrasound and only take out the other nodes if on ultrasound and on examination they start looking worrisome. And we believe that the survival in these two groups is the same. Now the initial data of this should come out within about 2 years here. So we're anxiously waiting for that. But all of this to really sort of say, we've gone from doing really wide excisions, taking out the nodes automatically, now to trying to do less and less surgery, really to decrease the morbidity for patients, but still provide the right treatment for our patients. So what about then with the new treatments that we have, all of these new drugs? Can they be helpful in patients with melanoma? And the answer is absolutely. I actually now do more surgery for patients with metastatic melanoma than I did before. The reason being is that we now have drugs that can be very helpful. And I'd like to illustrate that with a few examples here. So this is one of my patients that came in with a huge melanoma in a lymph node in the groin. And you can see this is very, very big. This is part of this is his hip bone over here. This is his bladder. And this is a very, very large. this cannot surgically be taken out. This is a huge operation, taking out his muscles, his vessels, and it's a very large operation. Fortunately, this patient was B-Raf positive, so he had a mutation in his B-Raf, and Alain will speak about that. So we actually gave him a B-Raf inhibitor for 3 months, and the lesion went down dramatically. You can see this here. Compared to that, it's much smaller. So now we could actually go back and take this out. And so we did that for 3 months and then took it out. When we took it out, there was no more melanoma left in there. So again, so this is how I think surgery is also really important in patients that have these metastatic disease. Another thing that Adil talked about is that we're using viruses now to try to treat melanomas. So the way this works is that we inject these viruses directly into the melanoma tumors. The viruses then goes in primarily into the melanoma cells. Once in the melanoma cells, they produce new virus particles. And this leads to the cancer cells being burst open. You have all of these cancer proteins that are then exposed to the immune system. The immune system says, this is not normal, this should not be here. And it comes in and starts fighting the melanoma. So we've been using this quite a lot. And Adil and Alain and the UCSF team have also been using some different plasmids, which is our pieces of DNA with electroporation. And what they do is they then provide a small current to get these plasmids in. And this has been very encouraging that we can use this. For our patients, when we do this, this is really well tolerated. Patients may have a bit of shakes and chills, same as getting a flu shot, but otherwise it's very well tolerated. So this is one of my patients that had a lot of these melanoma that's come back on the arm, these in-transit lesions. Remember I talked about the lymphatics, how you can have these melanoma cells sitting in those lymphatics, and they can then start growing. So this is the melanoma that grew in those lymphatics. We then injected this with the virus. You can see after a few injections, this has virtually gone away. And I saw this patient back actually last week on Wednesday, and it's got no evidence of disease right now. So very encouraging. And he's continued to do his normal activities. He did not have to stop work. And I think that he really can live a normal life with this. So let me show you then a case presentation, sort of another one of my patients. And so this is, again, a 68-year-old woman who back in 2004 had a melanoma on her arm. She did well for 4 years, but then developed evidence of a melanoma coming back in the armpit. She had that taken out, the melanoma taken out, and then went on high-dose interferon afterwards. Now, for those of you who've been on interferon, not an easy treatment to take. And she did well for a while, but then, again, developed evidence of melanoma in her breast, actually. And we saw her at that point in time, and then that was taken out, and then we recommended radiation to the breast. Well, she didn't want radiation, so we continued to follow her. And then she again developed recurrence within the breast area. So we then put her on one of these injectable studies, and she did well for a while, but then on a scan, as we do as part of those studies, we found that she had a brain metastasis. And it used to be in melanoma, if you had brain metastasis, the survival was not very good. That is fortunately changing now. But she had a brain metastasis. But it's really small in the beginning, and we weren't sure if that truly was a brain metastasis. So we did a scan 3 months later, and you see it had grown. So at that point in time, we said, well, it is probably a true brain metastasis. So we then did radiation of that spot in her brain. But she also had then developed other melanomas elsewhere on her flank, on her buttock, some more in the breast area. So we then, after we had done that radiation to the brain, we put her on another one of these injectable studies. So we injected actually the one in the flank over here. And this one here in the thigh was so small that we really couldn't feel, so this was not injected. But after 20 months on this treatment, we can still see the flank one here, but the one on the thigh has gone away. Another 8 months on the treatment, we still see this. Now, the way these studies are set up is that we can only treat patients for a certain period of time. So she came to the end of the treatment. We couldn't give any more of these injections. So we then discussed with her, well, what do we do now? We could still feel this thing on her flank. So she said, I just want it out. So we took it out. And when we did so, there was no more melanoma left in there. It was just scar tissue from this. And this was back in 2009. I saw her just in the New Year's here. Actually, her grandson plays in the same hockey team as my son. So, so we have our sort of impromptu, examination every at least twice a week. So And I saw her, and now it's over 5 years out, no evidence of melanoma, and she had brain metastasis. Again, encouraging for us with this. So the other thing that we're also doing right now is saying, well, if these viruses, if they help patients that have more melanoma, can we use this before we do surgery? Because we know that when patients have these in-transit lesions that comes back, such as this, or when they have lymph nodes that come back, the main treatment for that, if we can take it out, is still surgery. But patients have a really high risk of having melanoma come back. So what we often do currently in patients that have this disease, we take it out and then we talk about adjuvant therapy. These are additional therapies that we would give to the patient to prevent, if there are any cells circulating out in the body, prevent it from them from growing. Now, when we give that adjuvant therapy, interferon is still the main treatment for that. We can use biochemotherapy, we can use other clinical trials, but it so far have not worked very well. So now we're starting to ask the question, how about instead of doing surgery right away, how about we inject these first with the viruses, try to activate the immune system and develop this immune response against the tumor before we then take it out? Will that then prevent the melanoma from coming back versus doing surgery right away and then doing the adjuvant therapy? And the answer is we don't know that. But this is a one step that we're trying to do to try to help patients with melanoma and prevent it from ever coming back. So this is a clinical trial that we're running that we just initiated and looking specifically at that, where we're going to randomize patients to have these virus treatment followed by surgery versus surgery alone, and to see if we see a difference in that. So I think that in summary, surgical resection with appropriate margins should be done for all patients with primary melanoma. And sentinel lymph node biopsy is the standard of care for patients with clinically negative lymph node basins. And if the sentinel lymph node has metastases in it, still the standard of care is to take the rest of the lymph nodes out until we have information from the MSLT II study. But today, we would still take the rest of the lymph nodes out. I think that as new medical treatments are expanding, there's also an increasing role for surgery in those patients, as we talked about. I think that's why really melanoma patients should be treated in a multidisciplinary setting, similar to what they have at UCSF and what we have, where you really have everyone get together and talk about what the best treatment is for patients. And I think that adjuvant therapies in melanoma, the interference and so on, really don't work very well. We have to treat really 10 patients with interferon to benefit one. We need to do better than that. And I think for that reason, some of these neoadjuvant approaches, sort of giving patients some immunotherapies before we do surgery, we hope that that will improve the survival for our patients. So with that, thank you very much. Yeah.